Good morning. I am Camille Harrison, Group Vice President and Chief Customer Officer at Florida Blue. It is my pleasure to introduce you to this outstanding panel today who will be discussing emerging trends, innovation, and healthcare delivery systems. Our moderator for this panel is Renee Finley. She is the Vice President of Innovation and Market Research for Florida Blue. Joining Renee this morning is Thaddeus Seymour, Senior Vice President of Lake Nona and President of Lake Nona Institute. Also, Jenny Ehrlich, CEO, Clinton Health Matters Initiative, Clinton Foundation. David Metcalf, Director, UCF Institute for Simulation and Training, and Lynn Banaszak-Brusco, Executive Director, Disruptive Health Technology Institute, Carnegie Mellon University. You can read the details about these individuals in your program. I know you will enjoy the panel, and I encourage you to ask questions following the presentation. Please help me welcome our moderator, Renee Finley.
Good morning. It's truly a delight to be here with you this morning and to be really the moderator for this distinguished list of guest panelists that we have. I can assure you, you are in for a real treat. So as we begin today, I'd like for us to stop for a moment and open our minds and think about sort of a reframing, if you will, of the term health care. To begin to think about a broader definition of one's health ecosystem. This ecosystem really begins with the environment and the community that surrounds us. Does the built environment that we live, work, and play support the achievement of our personal health goals? Does it encourage activity and movement? Is my community organized in a way that allows me to connect with others who share my affinity in terms of my personal health goals or possibly a specific health condition, so that I might learn from them and learn from their experiences? Well, Lake Nona is a concentrated medical community just outside of Orlando that is aimed at doing just this. In a moment, you'll hear from Thad Seymour about the great work that the Lake Nona Institute is convening with both local and national partners to advance technologies and programs that enable stronger, healthier lives within the community. Likewise, you're going to hear from Jenny about the social determinants of health, with these outside influencers that are shown to have significant impacts on the health status, and how health policy and technology are enablers to driving meaningful health outcomes across our populations. And while policy and technology can certainly be enablers, the real transformation of health outcomes in this country will come from the collision of new entrants from outside our traditional industry roles, coming together with existing players to define these new innovations and new innovative solutions that solve the critical issues of access, cost, and quality. At Florida Blue, our collaborative innovation focus is on expanding access in rural markets with remote healthcare delivery. We heard from Dr. Smith this morning about the need to expand access and not have to actually come into the physician's office for a site of service. Our focus is in understanding meaningful consumer engagement with consumer interventions through the Life Study project that we're engaged in with Johnson & Johnson Wellness and Prevention in Lake Nona. We're focused on advancing retail consumer solutions through mobile health capabilities that provide simple, effortless, and timely solutions for individuals who want to be in control of managing their health or the health of a loved one. We really want to create this environment for consumer-driven health, not just patient-centered health care. Big difference. We're investing in entrepreneurs through our accelerator HealthBox to encourage and advance the development of market-valued health solutions, like YoFi, an online yoga and fitness solution, or eTech, who has developed an ingestible microchip that's embedded on a tiny pill capsule. It's activated by the acid in the stomach and then sends a signal to let your physician know that the medication has been ingested, really driving towards medication adherence, which is a huge issue in managing care outcomes today. Additionally, at Florida Blue, we are actively researching 4 key trends we believe are changing the very core of health and medicine. The first is biohealth. in which we're really trying to understand the efficacy and implications of next-generation sequencing, genetic sequencing, and the impact of personalized medicine and individualized therapies on formulary processes, or the significance of molecular regeneration, and this is where we're taking tissue from, for example, the arm, and using it to regenerate human organs. What is the implications of that on risk-based models of the future? Second area of focus is digital meets physical. This includes the device-to-device interactions, wearables, sensors, geospatial mapping, as well as gamification, where we use the digital world to connect with our bodies for monitoring and self-quantification of our health status. Our third area is remote health, which gives us opportunities for new sites of care delivery, to include everything from digital diagnostics from our iPad to self-enclosed care pods, to robotic surgery, to roaming robots that will be there during catastrophic events. And finally, our fourth area is big and small data integration that bring together not only the claims and clinical data, but meaningful, hyper-personalized consumer behavior analytics, alongside the unstructured data insights from the connected world of social interactions. With all this information coming together, we believe we can have differentiated insight that can drive actionable interventions with consumers. With these major trends at play, it's easy to see why innovation will come from non-traditional sources. Lynn will share what Carnegie Mellon, an engineering school, not a medical school, is doing to drive disruptive innovation in health. And also, David Metcalf of UCF will share with us some of the compelling examples of specific simulation initiatives he has underway in the Metals Lab that are already disrupting the marketplace. So without further ado, let me turn it over to Thad Seymour, president of the Lake Nona Institute. Please join me in welcoming Thad.
Well, good morning. I also want to echo thanks for this amazing event, to all the work that Velma and her team put into this, and all those who have done such a high-quality job at this. I've been in the past, and this is always a great and inspiring couple of days. So thank you for letting me be a part of it. I'm going to play the role, as Renee said, in kind of giving you an example of one community which we hope will be serve as a model for other ideas that can be applied in many other places. But sort of to kick off our panel, give you a sense of what we're doing at Lake Nona, and then we'll expand the panel from there. A couple of key themes I want to highlight, though. One is that, as Dr. Smith said, we also are very hopeful about the future. We have a lot of challenges in healthcare, but we're very optimistic about what lies ahead, and we're trying to live that in what we're doing at Lake Nona. Second key theme you'll hear from my remarks, and I think you'll hear from all the panelists, is that keys to the next generation of doing what we're trying to do even better is really are around driving innovation and doing that in a collaborative way. No one institution or individual is going to solve these important problems for us. We need to find better ways to work together. And Renee is modeling that, as is Florida Blue, the entire organization. We're trying to do that, and finding partnerships to make things happen is key. Third is that so much comes back to the individual, to shifting behavior. As Dr. Smith said in sort of an offhand comment, but we couldn't agree more, solving this problem of our own dumb behavior, how do we systematically address that? This is sometimes referred to, we like to think about this in terms of not just the biology of healthcare, but the biography that each one of us has and plays, and how that impacts our health. And then finally, how does the community play a role in affecting individual behavior? So those are the themes I want to highlight. And let me run through a very quick sort of visual virtual tour of Lake Nona and a little bit about what we're doing, and then close with some comments about specifically how we're trying to address and speak to this role of the role a community can play in driving good health in a population. As Renee said, we sit down in southeast Orlando, actually within the city limits of Orlando. right adjacent to the Orlando International Airport. What you see here is 7,000 acres, which is a big project. In fact, it's the size of Manhattan, if that's of any help, from Battery Park to Central Park. So it's going to keep us busy for a few years. But the chance to plan an entire community, which 20 years ago was all pasture land, with one little golf course plopped in the middle of it, is a remarkable chance to see what you could do in a community and how it might affect health. We have the great benefit in Lake Nona of being in the middle of, within the city of Orlando, in the middle of the third most populous state, and with an airport that gives us access internationally. And those are things that we think will be important as what we learn gets applied in other places in the future. Those of you who may know a little bit about Orlando may know something about this term, medical city. It's not a term we came up with. The Orlando Sentinel applied it to what was happening at Lake Nona a few years ago. But the reality is it's resulted in the last 6 years in $2 billion of construction in the institutions mentioned here, and it has gone from 0 jobs there 5 years ago to over 5,000 next year by the time the new Veterans Hospital opens. Just a quick view of these. One of our most important anchors is the UCF College of Medicine. Their entire graduate health sciences campus will be at Lake Nona. First 2 buildings are open here, a lab building and their education building. They're about to graduate their 2nd class, which we're very excited about. Tucked away, you see right next to them is the new Veterans Hospital. I'll tell you about in a second. Our second key anchor that came in 2006 was the Sanford Burnham Medical Research Institute. Their East Coast campus, main campus is in La Jolla, California. Their research focus is basic research in the fields of diabetes and obesity, particularly as it intersects cardiovascular disease. Incredibly important problem, and we believe some of the great breakthroughs are going to happen in this facility. Right next to them is the University of Florida. Very few places, if any, in the country where you have 2 large research universities actually cohabitating. Again, the spirit of collaboration to drive innovation. They have a College of Pharmacy here as well as several research teams. Our first hospital to open is Nemours Children's Hospital, headquartered up the road in Jacksonville, but this is their Florida hospital that opened in October of 2012. This is a state-of-the-art, first freestanding children's hospital to open anywhere in the country in the last 25 years, and they're off to a phenomenal start. And then the largest project of all is the Veterans Hospital. This is a 1.2 million square foot facility that will serve 6 counties in Central Florida. Orlando is the largest city in the country without a Veterans Hospital, so a very important need that will be filled by this facility that will open, has already started open in stages and will be fully open next year. We're about to break ground on our first real innovation center, which will be the key driver of commercial activity here at Lake Nona. And we're so pleased to have our anchor tenant and partner in that building being Florida Blue, who will occupy the full first floor and do amazing things there. We have a new medical office building that's under construction that opens this fall. And then we have an entire town center plan, about 1 million square feet of retail, restaurants, and shopping. And this first phase starts in the next month or 45 days with a hotel, an office building, and several restaurants. Our first restaurants in Medical City, so all our hungry scientists will be less grouchy, we hope, in the coming months. And then lots of room to grow over the next 20 or 30 years to really build out a real commercial center, an office park, a set of headquarters right near the airport. Mostly will be health and technology related kinds of organizations that we think will be very attracted to what we're doing. Now, as we think about how we're in this, with that set of anchors in that medical city, how we're approaching health differently, it really goes back to a vision we painted 6 or 7 years ago, which was very simply to build a place, aspirationally an ideal place, that inspires those who touch it, whether they live there or work there or study there or are patients there or have any other touch point, and that we do that through innovative collaboration. We were inspired by the work of an interesting book called The Medici Effect, which really, the name comes from 15th century Florence, which arguably was the first coming together of intellectuals in a dense urban place that led to the flowering of the Renaissance over the next several centuries. And it was this cross-pollination, this collaboration, this approaching problems differently that really led to that. And that's what vibrant clusters do, and that's why we think this place can be a part of trying to drive innovation in healthcare in the future. Interesting case study, a Harvard case study written a couple of years ago about this culture of collaboration that is very supportive to that. Well, we need to, though, focus not just on the healthcare institutions, but recognize that health is affected in all kinds of places. It's in the schools. So, for example, our first elementary school was a collaboration between the YMCA and a public elementary school, first of its kind, and for the last dozen years has been a A-rated school and a model for others to follow. We have a new middle school and a high school that have opened in the last 4 years, and right next to the high school, a campus for our largest community college in Orlando, Valencia, which is collaborating with the high school and encouraging students to take advanced courses even as high school students, with a real focus on health sciences and healthcare. And then we're also building, obviously, places for people to live. We have about 3,000 homes on our way to 10,000 when it's all done, thinking seriously about lots of different price points and planning that deliberately. But also, as Renee said, thinking about the built environment and how those places can affect the health of the population. And that's everything from trying to build most of the homes up to the sidewalks with front porches to create a greater sense of collaboration among the community members, to have green spaces intermixed, community gardens part of the project, and thinking about technology within the homes to be supportive of good health. This has become very quickly a very popular neighborhood, growing twice as fast as any other in the Central Florida region. And then finally, in terms of the built environment, we recognized in this century, one of the keys to driving innovation and creating a healthy, sustainable community was the technology infrastructure. You know, in the past, we've always thought about the normal utilities of water and power and sewer and gas. But in this century, fiber and information technology and bandwidth are equally, if not more important to many of the residents. Maybe not more important than water and sewer, but it's right up there, certainly to a teenage boy. And so we work together with our partners, the CIOs of our large institutional partners, to build a second-to-none fiber network within Medical City. And then maybe more importantly, recognizing that our workplace and our residential lives intersect so completely now. We needed to extend that same thinking to our homes. And so, sort of scared off by this discouraging picture, we said we can do this better. And so at Lake Nona, we turned that on its side, and every new home is armed with gigabit fiber, which is 20 to 50 times faster than you would buy anyplace else in the market, for less than you would pay to a traditional provider. We don't know what we'll do with that, but guys like David Metcalf and others will figure it out. And certainly these teenagers who are not afraid to think about what you can do with that kind of bandwidth. We had the honor of being recognized by Cisco because of that as their 9th iconic city and first in the United States, joining Barcelona and Rio and London and some others. So it is one of the handful of places that's doing this, but what we hope is many other communities will be inspired to do the same thing. So let me talk for just in the last couple minutes about how we're approaching the challenge of designing a healthy community. And you can read this, but the principle is that we so focus in this industry on acute care or secondarily outpatient care, but the reality is our health is affected by so many other dimensions of our experience, and so many of those are important parts of a community. So we believe there are a handful of things that really are characteristics of a healthy and fitness-friendly community. That we focus on prevention, keeping people out of the system. That the community resources and policies, whether it's tobacco policies or others, are embraced by the constituents in a community, and that the place supports and encourages physical activity. That we help a population prioritize differently than they might on their own. And that we find in that community lower rates of chronic disease because of the work that's been done. So those are some of the key characteristics. And so to help support that, we created a not-for-profit 3 or 4 years ago called the Lake Nona Institute, which has partnered with Florida Blue and a number of other great institutions who have helped us think about this. And you can see what we're about, in many ways using this as a living laboratory. And if we do that right and take the good advice we've gotten from those kinds of partners, we do things like encouraging healthy activity through the physical environment, but also through the programming that happens there. And we help people make healthier decisions, and it's with community gardens and health tobacco policies, et cetera. And as we build out the retail in the future, that will be a real test of what we can do and what a community will embrace in terms of healthier options going forward. We've used a prototype home as a way, working with Renee and David and others, to think about what role can a technology-armed home play in helping people make better decisions and live healthier lives. And so we've got a version 2.0 of this on the drawing board that we're working on and very, very excited about. And then finally, we've done this by embracing partnerships through great organizations, knowing that there's no limit to phenomenal ideas that can be applied. And one thing I'll close with is something that Renee mentioned. We're just about to launch a longitudinal health study at Lake Nona in partnership with J&J and including Florida Blue and GE and a number of others and our academic partners to be sort of a Framingham study so that while we're making these changes, trying to create this healthy community, we can measure that and determine what outcomes we're going to have. And if we do this right, we hope we'll have an impact way beyond the borders of what we're doing, not just in Orlando or Lake Nona, Orlando, or Central Florida, but throughout the state and beyond. And that's what excites us and leaves us optimistic and hopeful about the future. So with that, I'm going to turn it over, I think, to Ginny, who's going to take it from there. Thank you.
Great. Thank you so much, Thad and Renee, for those remarks. And I'll follow on and continue to dialogue about what I think we're starting to describe and I'll coin as the culture of health, really creating that surround sound of health in our communities, in our institutions, so that everyone really has the opportunity to be healthy and well. And want to also thank Florida Blue and for all of its leadership and thought leadership in this arena, and for really thinking from an innovative standpoint and really broadening the conversation. It's a great opportunity to do that today. I'm really pleased to be here. At the Clinton Foundation, we really work on, over the past 12 years, have worked on looking at how we can help people tell their best life stories, no matter where they live, work, or play around the globe. And we know that health is such a vital component of that work, and have worked in the child obesity prevention space for 8 years now, and over the past couple of years have broadened our work to chronic disease prevention and preventable health outcomes through our Clinton Health Matters initiative. As Renee mentioned, I'll share a little bit about the framework and paradigm from which we work and some of the work that we're doing to help be a part of the solution, recognizing that we are one entity of many, and in order to really move the needle around health and wellness in this country and really make sure that everyone has the opportunity to live in the community that Lake Nona is envisioning, et cetera, we need a lot of partners at the table, and you'll probably hear that as a theme throughout this panel and definitely throughout my remarks. I think everyone in this room can agree that in order to shift these numbers, we need to do things a little differently and perhaps think about healthcare differently. And I would suggest that when we're talking about innovations in healthcare delivery, perhaps one of the innovations is really thinking about how we change the paradigm of healthcare from a traditional system to a broader lens. And that in and of itself is innovation. Probably in this room, many of you are part of that choir, and recognizing that what happens within the healthcare walls needs to also transcend into communities. And we also know that the dialogue around current policy changes and transformation still really focuses on the traditional healthcare system, and we probably need to really change that dialogue and continue to help people understand the broader context of that work. I'm going to share a model called the social determinants of health model. We have a lot of data. I think some of my fellow panelists will talk about how we can better make sense and use of the data we have and use those data. But what I'll say is that we have a lot of data to suggest that while that traditional system is vitally important, it comprises probably only about 20% of one's overall health outcomes. So if we're really looking at measures and improving overall health outcomes, we need to think about socioeconomic factors like education and employment. The constellation of those suggests that the research suggests the constellation of those impact about 40% of one's overall health and well-being. We need to think about physical environmental factors, access to transportation, physical activity, healthy foods, clean air, clean water. That comprises a great percentage as well. And then, of course, healthy lifestyle behaviors. So this all together makes up what we often call the social determinants of health model. I think the opportunity that exists within this model is to bring people to the table and identify why they can be a part of the solution relative to health. Through our work, we're working with those in economic development, for example. We're working with employers. We're working with transportation. We're working with community investment firms, because there's a place for them, if we look at the right-hand side of this diagram, at the table, to be a part of the solution in a way that doesn't change their core mission or core strategy, but instead really helps them recognize how they're really contributing to the health of their community or their region or state or whatever their reference point is. The Clinton Health Matters initiative is hinged on this model, hinged on really looking at health more broadly, and hinged on identifying strategies that democratize the how and provide those opportunities to a broader group of people. We work on 3 core strategies. Let me say that these are not the only strategies we need. We need everyone in this room and beyond to really be a part of the solution. These are the core strategies that, as a foundation, we can really employ and leverage our assets. One is that we build strategic partnerships nationally to focus on core and key issues that we know will help move the needle. We also work at the community level, including here in Northeast Florida, to really look at how we can convene and broker solutions in communities and help move the needle in communities where we know the rubber really hits the road. And third, we work on digital innovation and how to catalyze and innovate and harness the power of digital solutions to be a tool. I'm going to talk about each one individually, and first around our national strategic partnerships by virtue of giving an example. These are 4 areas where we're working, but one I'll talk about in depth is our work around prescription drug abuse prevention. There are different aspects. We know that prescription drug misuse and abuse is now the leading cause of accidental death in the United States. It's a hidden issue in many ways, one that people don't really think about, but one that brings great challenges and opportunities to engage retail pharmacy, engage the medical community, but also engage young people, where we see a vast majority of challenges in college-age populations. It provides the opportunity to engage families who've lost people and loved ones to this issue. To that end, we formed a partnership by example of our work with the JED Foundation, which is a family foundation who lost a son to suicide and mental health challenges, with Facebook, and with MTV. This partnership provides college campuses the opportunity to take part in technical assistance and training and capacity building to address mental health, substance abuse, and prescription drug abuse efforts on college campuses. It recognizes campuses that really meet best practice in terms of creating a system and a safety net for all of their students as we work on this issue. We know that college students engage in a lot of social media and a lot of popular media. So we've been able to bring in Facebook, not probably the first group you think about when you think about prescription drug abuse prevention or even health, to really identify how through their broad social network they can provide tools and resources and guidance for friends who may have seen something on a Facebook posting that's scary or makes them wonder about how their friend's doing. They can push a button. They receive tools on how to talk with friends, how to navigate those conversations with friends, how to refer friends to support and help. They can also hit a button that triggers the cycling advertisements that come up for that friend to be focused on mental health solutions, hotlines, et cetera, crisis intervention pieces, and trigger an opportunity to reach out to family members and loved ones. That's an innovative solution from a partner that we may not have likely thought about. MTB is working with us by providing a public service announcement campaign, including many top performers that speak to people of that age, Macklemore being one, that really is talking about the importance of not mixing alcohol and prescription drugs and also not taking prescription drugs off use in a fun MTV-like way. So that gives an example of a strategic partnership and a creative way to combine some of the traditional forces that we often use around programs with media and different social innovations. On the digital side, we're working with many partners to really look at how we catalyze innovation, drive and accelerate new products to market, new applications to market, as well as to really use social media as a distribution network for best practice. One example of this work is work that we do with the Ace Hotels, Tumblr, and Jawbone. In that work, we have hosted 4 healthy codathons, or also known as hackathons, whereby we're bringing coders together. Again, people who aren't a part of our general health network, but people who code. And we bring them together and we give them an opportunity to compete by building applications on a variety of health issues: sleep, physical activity, healthy eating, stress management to date, as well as others. But what we've done is change the codathon or hackathon environment so that they're not drinking beer, eating pizza, drinking a lot of coffee, and staying up all night during their 72-hour experience, which is the typical codathon, hackathon experience. Instead, we put them up at the Ace Hotels. We give them personal sensor devices, up bands from Jawbone. We incorporate physical activity breaks. We only provide food that meets key nutritional guidelines. And we factor in their step and their sleep scores at the end of the day when they finish their competition. So as the judges are judging the different entries for innovation, they are also judging if that team really walked the talk throughout that 72-hour experience. So again, partners that maybe we didn't think about, Ace Hotels, something that's very attractive. Coders who might be thinking about different innovations, but guess what? 3 of the 4 entries that have won these 4 codathons are at market or going to market. So there's also an economic benefit to this type of work. So that gives an example of some innovation that we're doing, but we also hope to scale with a variety of partners. And lastly, we're working in communities, recognizing that this is where it really happens, and that if we're really going to equally distribute the opportunity to be healthy, we need to impact the overall community. We're working in 4 communities to serve as catalysts and brokers for change, to really look at how we don't deliver new programs, how we don't add kind of another NGO to the mix, but really try to convene people across partners as an organization that can identify what the community believes its priorities are, identify what the big bets are, We build those big bets based on this model on the right-hand side. And with those big bets, we then really try to serve as that neutral broker convener. We look at how we can provide national resources through our national partners to help move the needle in a way that makes sense to the community. And we help identify how we can convene community partners who've never come together before. For example, in the Coachella Valley of California, where we have been working the longest, we convened all of the health IT leaders from across the healthcare systems with Verizon, so that Verizon could identify how they could really support through their various properties the needs of that community. Those health IT leaders from those various systems said they'd never really been in the room together, even though they knew who each other were. So it gives an example of just some simple solutions that help move the needle. That has ended up building cellular infrastructure around the federally qualified health centers in that region, where there are weather conditions that make it so that they didn't have really reliable cellular infrastructure, just to give you a sense of what types of solutions are at play. We're really pleased to be doing that, this work in Northeast Florida. Our regional director, Ashley Smith-Juarez, is here with us. So Ashley is leading that work in Northeastern Florida. We're just getting it off the ground here. We know many of you were a part of that session to really identify the big bets and really appreciate some of the early partnerships that we're seeing. The goal is to create the collective impact that we're seeing in regions we're further along, where in the Coachella Valley, for example, there's been about $11.3 million of new health investments relative to their blueprint for action in just about 18 months. So we're really excited to start to see the needle move there and start to see the needle move here in Northeast Florida as we continue this work. In closing, I'd just like to go back where we started. We know that if we think more broadly, we actually have more opportunity to bring partners in who we might not have otherwise thought about. We have the opportunity to drive innovation and drive economic opportunity for coders, for people in transportation, et cetera. So that's something that is a selling point, I think, as we think about our paradigm being health to a broader community and to a broader cast of characters who can really help us move the needle. We also need partners to really identify how we can democratize the how we can continue to distribute lessons learned, and really create a culture of health no matter what one zip code is. I think that's our biggest challenge. I think if we're really going to drive down the numbers that we're seeing now, with more than 70% of adults in the United States with chronic health conditions, we really need to think differently and more expansively, and look forward to continuing the conversation and hearing from other panelists who will share some of their work toward that end. Thanks so much.
Hi, I'd like to echo the comments of some of our panelists as well, too, and thank Florida Blue and the Foundation for putting on such a great event. I wanted to talk to you a little bit about some of the things that we're doing at University of Central Florida, but maybe also talk more broadly about how some of the dizzying pace of innovations that are coming at us on a constant basis are things that we have to figure out how to sort out, not only for our own medical students and the things that they're driving forward as the next generation of leaders, but how these are going to come into our communities and how they're going to serve us and our populations too. So with that, I want to give you this little speed tour, maybe starting off with a little bit of information about our particular university, for those of you that aren't familiar too. We have a lot of students. We have a new med school, and we have been known for things like game design and computer science students, and tying those types of things together in our community. Our Institute for Simulation and Training is one of those places that brings together communities like our traditional military and scientific community, which has been in effect for 30 years plus in Central Florida and Orlando, and with the new emerging, rising from the ground Lake Nona community and Medical City that's springing forth too. Merging these two communities, the technology and the past background, the evidence of effectiveness for human performance and learning, with some of the cutting edge medical education and medical science is part of what we're trying to do. We've been working with our College of Medicine since its inception in 2009, really kind of getting to build some of the technologies that are going to be used by not only our med students, but our next generation of medical providers throughout both our community and throughout the world. And these are some of the different types of areas we've been looking at too, anything from the enterprise systems that support medical education to things like games and simulations, mobile technology, and how these are being integrated. So I wanted to give you a little speed tour of a few of the ones that we're exploring right now and how they're coming into fruition, not only in the med school, but throughout our community. Our laboratory is focused on learning, performance, and well-being, using a lot of the technologies that we see every day, like mobile technology, games, collaborative systems, and social media, and tying those together not only for our own internal purposes, but also for the partners that we work with from outside in the community, places like Johnson & Johnson, like our military, McGraw-Hill, and doing things for the community as well, too, like STEM education projects and other social good. We're trying to make some of these as simple as possible. One of the things that we've put together for our doctors and the staff and the faculty at our College of Medicine is something we affectionately call apps in an hour. How can you take the things that you need to do for anything from clinical case studies, podcasts, medical informatics, and make those as easy to put together as just a few steps that you can do in less than an hour? And we also tie that with some of the advanced technology that simplifies some of the most daunting and complex tasks that we've traditionally had within medical schools, and bringing that out to a broad base. A few years ago, we got a grant from the state to form something called SHELL, our Simulation for Healthcare Education Learning Lab. And I was really enlightened and humbled by some of our both students and junior faculty who came up with some incredible cost and time-saving innovations, as well as the technologies that were applied in things like building our standardized patients so that they are scientifically and medically accurate down to every single dot and pattern that you would see on skin, and being able to tie that together with some of the things that you can do with 3D printers. So I see mini-me there as well too. But you start to be able to tie together some of these components with the traditional technologies that we keep hearing about, as well as the new cutting-edge technologies. So that was the outside of the body. The other thing we can do now is take the inside of the body. Give us any set of MRIs or CAT scans, and we can, in less than 10 seconds, produce a photorealistic 3D model of that environment. And bring that forward in such a way that it could be used and personalized to each individual med student's book with their cadaver. Instead of a traditional anatomy book that has cells and foils in it, you'd actually have the ability to have the cadaver you're working on in the morning show up in your textbook in the afternoon, so that you have a very personalized experience, customized and tailored to what you're trying to learn. We wanted to bring this out further too, so we built a mobile app that works on anything from a traditional BlackBerry all the way up to the highest end cell phones and smartphones or your desktop, and gives you the ability to go in and see this medical imagery and take layers, put layers off and on. Things you normally only have in a $2 million plus clinical system, you can now bring out to rural health clinics across the globe. And we've tested this in places like Kenya and Haiti and other locations too, to see if this works, and made this freely available as a viewer. We're still trying to solve some of the HIPAA policy issues to be able to do the other side for free too, of allowing you to upload your imagery to and serve your global audience. But we are interested in partnerships around those areas. We're adding this to the traditional clinical health record too, that you find in electronic health records. And this may not look like it, but this is actually from Ryder Trauma Center, from their where the VA and the Army come together too to serve level 1 trauma care. And it's an overlay on top of 3 electronic health record systems. So this is a voice and gesture controlled system that, instead of having a black screen with green text on it, you have gesture control to be able to go down and see your imagery, to be able to go and also have all of your medical education tied into the context of what you're learning too. They have many residents there, and you've got to think about the fact that they're still maybe looking up things or learning things too while they're in rotation or in procedures. This gives you access to all the information in context about whatever you're looking at right there at your fingertips, in addition to the 3D clinical imagery that you were seeing that you might have had for medical education. Tie this together with links to things like IBM Watson, who's heard of this system too, played Jeopardy against some of the world champions. I got to see this about a year and a half ago, really go and in 3 seconds or less do a differential diagnosis over a phone with the lab work behind the scenes. This is going to change the way we get secondary consults, our doctors get secondary consults, and these are the types of things that are being added to the mix, along with things like wearable computing too. This is a mock-up of what an iWatch might look like in the future, not the real one. And you see Google Glass there too, which might present doctors with an overlay of digital information, sort of that digital to physical divide that Renee was talking about too. But how do we bring this to all aspects and areas of society? Some of the work that we're doing globally with our teams in the Yucatan that our med students go to visit in Dominican Republic, as well as the work that we do from National Science Foundation in Haiti and work that we do in Africa, points to how we can take these same technologies and bring them out to the field and make it so that we have things like disaster response with those electronic health records right there at the fingertips of people, even in remote areas with no cell signal, and adding those records and the ability to go and solve logistical problems as well, too, to the mix. In many ways, we're seeing this leapfrog effect, too, that's happening in our rural communities here in the U.S., as well as in places like as far away as Africa, too. If we can start to solve some of those problems, we can bring back things that are 10 times the cost innovation back to the U.S. We're seeing things happen there without FDA trials and other things like that too, but with still a quality of care and evidence-based approach to seeing what works in other countries and bringing that back to the U.S. In that spirit, we tried to put together suites of tools like test beds for some of the wearable electronics, and then put those into practice in places like the intelligent home that Dr. Seymour talked about as well, too. And the intelligent home has things like a dashboard that's built into a mirror that gives you your personal health record, taking some of the medical informatics and information that you saw already, and making it ambient in the home. Now again, this is in a very, very nice home and gives you an idea of what you'd be able to do there, but how do we democratize that and bring it out to people for $1,000 or less, $200 or less, $50 or less, to homes across America too? We want this to be a test bed where we can work out some of the issues and problems and then start to drive those scalable issues too. With help from places like the U.S. military, which is also exploring some of the cutting edge of mobile app development for their medical and military personnel, we're able to leverage things like augmented reality, the same thing as Google Glass uses, to do instant recognition of patient records and to be able to tie into public health campaigns too, so that when you go into a doctor's office and see a poster, you might be able to just go up and click on that poster. Coming up. Yeah. All right, we'll go back to the area here. Click on that poster that you'd see. And when you click on that poster, you actually can automatically launch into a health campaign that starts with a video, gives you text messages or emails on an ongoing basis to drive, hopefully, some of that behavioral change that you talked about in your model as well, too. Tying that together with other systems like the ability to have clinical visualization systems, have advanced laparoscopic surgery trainers, these are all things that our students are being exposed to now for that next generation. Anybody know what this is or seen this particular TED Talk? This is, shows a demonstration of a liver and a kidney being printed from a 3D printer. So you start to look at the ways that things are coming together and converging rapidly. We want to have evidence-based approaches to how we put these into practice, and of course these need to go through FDA trials, but these are things that hold great promise and also an opportunity for responsible integration of technology in the future. Our students are are being encouraged to do this through the Healthcare Innovations Group at the UCF College of Medicine, which has had great support from places like Lake Nona and Florida Blue and others in our community as well, too. Because we're not going to be the drivers of this. Again, I'm constantly humbled by what our students are doing and what our faculty are doing and how these are starting to converge and come together. So, as a public nonprofit university that's in our general area too, we see that a lot of our responsibility is to take some of the great things coming out of places like Carnegie Mellon, to be able to take some of the great findings from across the globe that have evidence behind them of effectiveness and be kind of that demilitarized zone, to partner with industry, government, nonprofits, and to help launch some of the other small businesses and have the R&D leverage to grow that next generation of leaders that we're hoping to educate. So that's really some of our goals, too, as a partnering university. We like to think of ourselves in joining into some of these broader, internationally relevant partnerships, and to take the resources and strategies and not only spin off companies, but also grow that next generation of leaders, not just technologists, but also in the clinical practice. So lots of room for additional information. We have a couple of books on these topics, too, that I'm going to donate one to your library as well, too, with Florida Blue for our new Health Innovation book that just came out, too. And I'll leave with that, too. So thanks.
Good morning. It's my pleasure to be here with all of you today and talk about what we're doing at Carnegie Mellon University and how that sort of pertains really to what everyone here has spoke about thus far, which is a shift in practice, a shift in culture, a shift in the way that we do things, and also utilizing existing ecosystems that perhaps weren't utilized in healthcare before to make an impact in the way that we deliver healthcare. I and the Disruptive Health Technology Institute at Carnegie Mellon University is just under 1 year old. And so I'm just under 1 year anniversary with the Institute. And it's funny that, you know, when I took the job, my parents said, well, what is it that you're going to be doing? And I said, I'm going to be disruptive. They were like, well, is anyone ever going to want to have a meeting with you? That's, you know, your title says disruptive. They didn't really get that that word really is meant to push us forward. And so I'm going to talk a little bit about that today and how Carnegie Mellon University is working with two very strategic partners to be disruptive when it comes to the delivery of healthcare. And so, you know, in the past, when we're talking about eds and meds, certainly Pittsburgh has always been a really good place for university-centered innovation. And typically, academic healthcare centers have received a lot of their investment from technology that comes out of universities. But you know, why is it so slow? I mean, typically in the past, when we were talking about growing innovations that could change healthcare, the tendency was to focus on those things that were really maybe long-term game changers, or things that were very biology-based, that perhaps would take a lot of regulation and a lot of time to come off the bench and be a solution that could actually meet an unmet clinical need. Typically in the past, the payer community, by choice, almost never would participate in inventing the future of healthcare, would sort of be waiting in the wings for those innovations or technologies to come together as solutions. What we're trying to do at the Disruptive Health Technology Institute is not unlike the situation that happened in the automobile industry in the 1950s. The Insurance Institute for Highway Safety in 1959 was formed by three major insurance associations, which captured about 80% of the market at that time. They were the people that were serving the drivers, that were serving the driver safety in some ways. And what they came together to do was sort of solve the fact that automobile manufacturers did not care whether cars were crashed, because it meant that they could just sell more cars, right? And so the insurance industry came together at that time to say, how can we really change the approach to make sure that the drivers, their safety, the losses attached to things, the impacts and the damages are also part of sort of the front end of how innovation is put together. So we're learning at the Disruptive Health Technology Institute, and part of the conversations that developed us were, how could we identify a world-class innovation engine that did not sort of have the medical school politics attached to it, to driving medical innovations off the bench? How could we take data mining and machine learning to identify innovation that would drive down cost and improve outcomes in healthcare? How could we use competition to identify these technology-based solutions? And finally, how could we financially align the payers with the technology at the very beginning of the process? And so the word disruption really came about through a researcher by the name of Clayton Christensen. His work at Stanford was really around big data and around information technology back when he coined the phrase. And essentially what we're trying to do at CMU right now is create disruption. And disruption is simply created when you take a huge technological leap in a very short amount of time, and you get that solution out to consumers and into their hands so that it can begin to be implemented and change the way things are done. So Dr. Alan Russell, who's the director of our institute, loves this quote from Walter Cronkite, which is, "America's healthcare system is neither healthy, caring, nor a system." Right? And so what we're trying to do is sort of dispute that quote from Walter Cronkite by bringing science and technology together to create affordability, quality, simplicity, and accessibility for healthcare all at the same time. And so when the minds got together and said, how can we utilize this non-medical school for essentially a delivery point to bring affordability, accessibility, simplicity, and quality of healthcare solutions into the marketplace, Carnegie Mellon University was at the top of the list of the discussion in the region. You know, Carnegie Mellon University, when you think of our institute, maybe you don't think of us, I hope that you do, but when our institute is typically, our university is brought into conversations, we're talking about gaming, we're talking about computer science. We're talking about the Entertainment Technology Center, which has an affiliation with Disney. We have traditional relationships with organizations like NASA and DARPA, the NIH, but we also have very close relationships with places like Google and Bill Gates, and both his technology and philanthropic ideas. And so the Disruptive Health Technology Institute really was started with the partnership of 3 very important players in the greater Pittsburgh region. As I said, Carnegie Mellon University has a very distinguished reputation in the world for things that pertain to computer science and finance and social economics. We are always in the top rankings of universities nationally, globally really seen as the #1 school in using big data and machine learning to solve problems. Highmark, which is the Blue Cross Blue Shield provider in the greater Pittsburgh region, is the 4th largest in the United States. Certainly, there's a huge contribution to the community and the health of the community. Highmark recently, again about a year ago, purchased its own hospital system in Pittsburgh. And so there are 7 hospitals in that system. And what this unique partnership has done is taken an innovation-driven university, partnered it with a payer that cares about delivering healthcare in a more efficient manner, and gives us now a clinical partner where we can deploy those innovations quickly to figure out if they are going to work just in the system or if those are things that we can take nationally. So we really started our bench to bedside, how to get innovations off the scientific bench and into patient care with a very strategic way of thinking. And so we have, for about 26 months now, sat together with the clinicians at the Health Network, sat together with the administrators at Highmark, and sat together with the principal investigators and the big brains at CMU to have these retreats around what are the clinical problems, what are the things that our clinicians care about, that if only they could be fixed could make a huge, quick difference in the delivery of healthcare in the clinical site. But also, as you can imagine, the amount of rich data that Highmark is in possession of. How can that data be shared? Aggregated, de-identified, but kept in a rich, robust way that that data can be shared for trends analysis, product development, anomaly detection. So we sat together and came up with our ways, our problems, and then took those problems that the ideas were sparked from, developed our areas of focus, which you see on this slide, and are working right now to fund projects in those areas. So Highmark has made an $11 million 5-year commitment to the Carnegie Mellon University to invest in innovation. We do that through a request for proposal process. We had one request for proposal last spring. We had 50 proposals come through, all of which were great ideas for deployment. We just last week sent out our second request for proposals. We're investing in science anywhere from $150,000 to $300,000 in each of those ideas through the Institute. And what we are expecting from the innovations that we are investing in is that those innovations will be deployable in a very short time. So their ability to disrupt how things are done can happen in 2 to 3 years after that the diligence has been done on that innovation. And so I wanted to just, I'm not going to go through these in detail, but I wanted to give you an idea of just a few of the projects that we funded. So when we're talking about sort of the home environment and patient-centric ways to monitor healthcare, there is a group at CMU led by Dr. Jessica Hodgkins, who is one of the chief innovation officers for Disney. She's also one of our principal investigators at CMU. And one of the problems that clinicians talked about was patients that have debilitating disease like Parkinson's disease, for example. It's very hard to help and evaluate them in a 10-minute appointment, right? Patients talk about the things that are ailing them. In those 10 minutes, you try to make decisions about medications and other things. And so what we've come up with is sort of this home-centric, digitally enhanced environment where patients can be observed and their movements can be observed. And a doctor in real time can get data around that information to determine what's a shake, what's a tremor, what are big movements, to determine really what the general landscape of that person's daily life is and how medication and treatment can best help them. Enhanced colonoscopy, a subject we all really love to talk about, colonoscopies. It's taken me almost a year to say colonoscopy without, I didn't, right? I had to make fun of it again. But what's fascinating about this project is that doctors talk to us about the fact that at any given time when a colonoscopy is being performed, most likely about 70% of the colon is being observed. There's anywhere from 30 to 40+% of the colon that was not even evaluated. And as you can imagine, with such a great success rate that if you find polyps early enough, the colon cancer really essentially is curable, it's important to sort of bridge that gap. Dr. Yang Kai, who is the director of the Visual Intelligence Studio at CMU, is one of the world's foremost authorities in things like facial recognition, traffic patterns, observing things in a big way and coming up with solutions. What he has proposed is that similarly to the way that Google Maps has sort of taken all these flat photos of the Earth and then wrapped them into a 3D model that we can drill down on and literally take a look at any pinpoint on the globe, essentially, he believes that he can do that with the colon. And so in real time, add a scope onto the colonoscopy camera where doctors will know where they've already been, where the areas that they've missed. In addition to that, he believes that he can study the topography of a healthy lining of a colon and determine subtleties in that lining that are pre-polyp. And so give the doctor an opportunity, sort of with the circling of an area, to go back and really take a look at something that perhaps with the naked eye, he or she may not have observed as easily. Another one is our next generation generation ECG machine. As you can imagine, wearing Holter monitors, those kinds of things are very cumbersome. They're not completely sensitive. It depends on your body type. And so the really big brains at CMU's Robotics Institute, a place where they use big data, software integration, and robotics information to solve problems like unmanned robots that go into mines and really interesting things that they're doing in space, have figured out that they really can have a real-time vest for people where digital information is being shared with the doctor during that time that you're wearing the vest in a much more robust and intuitive way than just that one-dimensional way that we study it now. And the last thing that I have images here for is in our biological science area, one of our doctors, Dr. Adam Lindstedt, has discovered there is a foodborne toxin called shigatoxin that is deadly. It's something that happens, gets into your system, and antibiotics, not all antibiotics, but lots of antibiotics actually make it worse. And there's no real cure once you get beyond a certain threshold with this toxin being in your system. He's realized that a simple supplement, manganese, can actually change the direction of that degradation pathway and essentially make shiga not toxic in the body. And so we're interested in the novelty and the disruption of using something that wouldn't need an FDA pathway to be approved to solve a problem that right now, in places where there's dirty water and people don't have the food sources that we may be lucky enough to have, are dying of something that's very, very deadly in certain populations. This project is using red light to kill biofilm on implants in the body. And so I won't get into all of that, but it's interesting that these, the doctors, as they sat with the principal investigators, because they're roboticists and they're big data, and they have different minds than typical healthcare clinicians, came up with very sort of pragmatic solutions to a lot of the things that these doctors talked about. Well, we could just use red light to kill those toxins. And so it's interesting as we sit together and more of the milestones on their research are being reached, how the doctors are really being fascinated by some of the simplicity of the ways these solutions are coming together. So in the interest of time, I won't go through the rest of this in detail, but what we're trying to do at Carnegie Mellon at the Disruptive Health Technology Institute is really focus on P4 medicine, which is things that will become personalized, predictive, preventative, and participatory. And so with our partners at Highmark as a payer and the Allegheny Health Network as a healthcare delivery system, we're really trying to work on fast and furious ways to make that happen. We believe that disruption will definitely drive change in the way healthcare is delivered. We want the way that we're doing things to be a scalable relationship. We want the innovations to be scalable. We want to work together to sort of change the ecosystem that innovation typically has been driven off of the bench in science in the past. And so I wanted to just share this photo with you because I think it's an interesting photo. This bridge was built in Honduras in 1997. It was this waterway, the river that it crosses, was a very important part of the Pan-American highway, very important to commerce, very important to keeping the country a part of the world's marketplace. The bridge was built with all the intention to withstand anything, to be a strong and everlasting bridge. So, in 1998, Hurricane Mitch hit. And it was so powerful, there's the bridge, it was so powerful that the river literally rerouted itself. So here you have a bridge, right? And I compare the bridge in some ways to our healthcare system. right? Is it a bridge to nowhere? Perhaps, if we continue doing things the way that we do them, right? And so our system was built, it was built for purpose, it was built to last, it was built to take us from one place to another. But like the river, healthcare has changed. We're rerouting. And so I think, it's a must that we, as people who care about the way healthcare gets delivered to people, that care about how we deliver it in many different ways, have to understand that the system, the bridge to that changing healthcare system, has to change. And so we don't want our healthcare system to be essentially a tourist attraction. We want it to be a place that gets us to the what's next. So thank you.
So my sincere thanks to each of you for really bringing a very fascinating and compelling story to us today about what's happening in the transformation of healthcare. And more importantly, for your collaboration and also partnership with us at Florida Blue. We really do appreciate and value your time today. So as you've heard, the transformation of the industry is here and now. It's not someplace in a future time. Technology and medicine are rapidly advancing, and our ability to learn and adapt is growing at an exponential pace. There are new entrants, there are new solutions being introduced to the market on a daily basis, and as we heard, it's really only through this collision of the old and new, and all of us working together as partners towards this one common goal, where we can really find meaningful innovation. So we want to thank each of you today for being part of this journey with us. Thanks so much. And with that, I'm going to open it up to our panel to answer any questions that the audience might have. We've got about 10 or 15 minutes. Any questions?
I'm thinking about privacy, and some of you mentioned HIPAA and those kind of things. Do you all see, as you're doing this work, is there any laws or regulations or policies that need to be changed or looked at through a new lens to allow some of these things to happen?
I'll start since I brought up HIPAA. To give you that example of the 3D technology, if you think about that, that could be seen as a series of stills rotating around. We don't have clarity from our legal department on whether a medical record is the whole of that 3D model or each individual frame as it rotates at $5,000 per record fine. So things like that certainly inhibit us from a policy standpoint from pushing forward too fast on things. But of course, we know we need regulation as well too, because we value and respect the privacy of your patients and the people that you work with as well too. So we know there's a balance, but those are some things that we struggle with that maybe keep the innovation back at the bench a little bit longer than maybe some would like before it can be deployed.
I was going to say from a data standpoint, it took us a good 9+ months to get that data agreement between Highmark and Carnegie Mellon finalized. There were a lot of legalities because, as you can imagine, there are privacy rules that pertain to Highmark protecting the privacy of their clients that don't typically pertain to the way data is used in a university. And so there was a lot of effort to make sure we bridged that gap and all of those privacy issues would be addressed in the way that we shared data. The one data project that we're working on is anomaly detection in a large, robust sampling of data from Highmark. And so I think the fact that we took almost a year to figure out how that relationship could bridge all of that policy was important, because we don't live in the same world, and so it's hard to align those things in some ways. But it delayed the research for 9 months, and so I think it was a lesson that we probably have to get a little more on the policy side of things and be driving some of that change, because the conversations haven't existed previous to now, and so policymakers themselves haven't really even understood what the questions were.
I have a question actually for Thad. What roles do you see for nonprofit health or community organizations in Lake Nona?
Well, it's a great question. We start with this premise that it really does take multiple partners working together, and each one brings a different point of view. I have the honor of serving on the board of a community organization in Orlando called Shepherd's Hope, which Florida Blue has been a wonderful partner and supporter of, and we provide care for uninsured residents in Central Florida, and about 20,000 patients a year. That, as an example, hasn't gotten involved in Lake Nona, but will over time, and many others like it. I think one of the challenges, one of the reasons we created the Institute was to play that convening role, as Dr. Smith was talking about, and helping to not make it easier for multiple organizations, each of which brings its own expertise and passions and skills and connections, and try to organize them and work in a way that for us at Lake Nona can cut across prevention, can cut across a continuum of care, filling in the gaps that the large institutions don't provide. So if we don't do that well and have those not-for-profit organizations working together, and I would say this is true for any community, and those that are doing this best are frankly doing a better job in creating healthy populations. If we don't do that well, we won't fulfill our vision.
Great, thank you. Questions from the audience? Yes.
A follow-up on Susan's question for Lynn. With regard to the information, and you said, I guess the dynamic is Carnegie, Mellon, and Highmark in the negotiation between patients' records and where the data comes from. Why not just ask the patients themselves if they wanted to be involved? And how would that work if possible? Because I'm pretty sure most people, especially those who are aware, would have no problem volunteering that type of information if the study were for a reason that they supported and or knew the importance of.
I think that's a great point. I think being just not even a year old, so our first part of our relationship with Highmark, as I said, we're essentially in place to solve real problems that were in the system. And so the data-driven problems that we're working on right now are payer-centric problems. And so with all of the new policy around the Affordable Care Act, there's a shorter retrospective for Highmark to go back and make sure things were coded properly and that patients are aligned to the proper coding. And so the first iteration of this project is to make sure that we're helping Highmark understand their data earlier so that they can utilize the shorter retrospective more efficiently, or hopefully don't need it at all because they'll be in front of it. The second part of that, having this data though, is really more of a patient-centric thing, which is how can we look at the trends of data and the types of treatments that are in patients' treatment plans and figure out if X always leads, in 6 months, X always somehow led to Y, then maybe there's an opportunity to intervene with some type of treatment earlier. Because if we know patients that have these type of treatments pathways likely always end up here, then maybe there's a way for us to help them sooner in their treatment plan. So the next iteration of that will be to use the social economists and the other people at CMU to do more of a patient-centric combination of having the de-identified data, coupling it with very specific projects that have identifiable patient data, because to your point, they've agreed to be part of it. And so I think it'll be a natural, organic part of the Institute's growth. And also, the credibility of the research. Once we have some wins and some research that's beyond just 9 months old, and we can show that they've hit their milestones and are making a difference, or deployable, essentially, then I think there'll be more of an opportunity to engage people from different parts of the conversation.
Great question. Other questions for the panelists? I actually have one more for Jenny. So you talked earlier about the work that yourself and Ashley are leading here in Northeast Florida, and we applaud your efforts and thank you for being part of our community. I'm wondering if you could share any early insights about some of the emerging priorities that are coming out of that conversation?
Sure, and we are early on. We are probably just a few weeks from releasing our Blueprint for Action, which is a document that will identify the big bets that the Northeast Florida community helped us identify through a strategic planning session in December. So let me share that we're very early on in the process. That being said, Ashley has done a really great job of engaging a variety of partners throughout the region, and the region has really stepped up to identify opportunities to collaborate around research and evaluation around measurement. We've been really thrilled with Florida Blue coming to the table around a variety of issues, including that one, as well as looking at digital innovation and looking at how we can leverage digital solutions in the region. We've seen great early partnerships from the academic institutions in the region in terms of coming together around those issues, but also how to engage their various student bodies in the issues. This region is so rich with resources from an academic standpoint. So the PGA Tour is our sponsor. They've, of course, been a great partner and really helped with the integration into the region and really providing great introductions. And then, of course, you know, the more traditional communities like the public health community and education, which we certainly don't take for granted, have been really, really supportive of our early efforts.
Thank you. Any final questions? Yes.
This question is for Lynn. Lynn, on your slide, it mentioned about infection prevention.
Yes.
And I wanted to know what's being done as it relates to patients being hospitalized and infections being so prevalent in the hospital settings.
So the projects that we've received proposals for sort of run the gamut. So one that I didn't spend enough time on perhaps was the biofilm resistance. And so with all of the implants, knee replacements just being one that are happening for patients, certainly infection is a big deal if that happens and you have something like a knee replacement that ultimately might need to be redone. We are working on different innovative ways, particularly in that one, to use red light to kill biofilms on the device through the skin so that the infection subsides and there's no further treatment. But there are other interesting things using digital information. Hand washing, for example, for physicians. You talk about a cultural shift. So there is this device that essentially is like a bracelet that knows the difference between hand washing motions versus waving or other things. And there's this innovative company that's formed out of CMU that really thought if we could get clinicians to wear this device, maybe it's just a pin, maybe it doesn't stay as a bracelet, but maybe it's just a small chip on their sleeve or a pin or something where we could determine the level of proper hand washing going on in a hospital as doctors and nurses move from one patient to another as a very quick and easy way to determine. But as you can imagine, a lot of people would have to agree to want to do that. But so we've been thinking about innovation, infection prevention very pragmatically, something as simple as washing your hands and something as sophisticated as a device that can help kill bacteria that's forming in a biofilm while still in the body. And so I think, you know, give us a little more time. Infection prevention, so in our RFP that we just sent out last week, infection prevention is still one of the key areas that we're asking researchers to think through. And so we're trying to also engage patients in different behavioral change through our social economists. And so we're trying to approach it from all sides. So stay posted on what our results are on those projects.
Great. Thank you, Lynn. Okay, we are out of time, so I'm going to wrap with that and invite Susan Toller to give us next steps. Thank you.